Hello and welcome to another intensivecarehotline.com live stream and also intensivecareathome.com live stream. Thank you so much for joining today, so close before Christmas. For those of you that have loved ones in intensive care over the Christmas period, I just want to let you know that we are here to help you even over the festive season, because we know that's probably when you need us the most, managing those challenging situations in intensive care. Before we get started, just want to welcome you and also thank you. We've already got the questions here lined up. I want to thank you for your participation and for your engagement. I will come to those questions in a minute. Before I come to the questions, also want to welcome the viewers that watch the replay, watch this on replay. You're still welcome to type questions in here. I can also get you live on the show in a minute after I've gone through the questions that have already been asked, if you wanted to ask questions live on the show. Now, before I go to the questions, just very quickly, what makes me qualified to answer questions for families in intensive care? My name is Patrik Hutzel. I'm a critical care nurse. By background, I have worked in intensive care, critical care for over 20 years in 3 different countries, where I also worked as a nurse manager for over 5 years. And I have been consulting and advocating for families in intensive care for over 10 years as part of my professional consulting and advocacy service at intensivecarehotline.com. I'm also the founder and managing director of Intensive Care at Home. You can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies. Currently, we are operating all around Australia with Intensive Care at Home. We are NDIS, TAC, iCare, NIISQ, DVA approved service provider. We also have received funding through public hospitals, departments of health, and also private health insurances. So, but even if you are in the UK or in the US or in Canada and you need intensive care at home, please reach out to us. We can most likely help you in those countries as well through other avenues. So please reach out one way or another. Now, let's go to today's questions. We'll probably be going for an hour, up to an hour. That's how much my time allows. So please keep shooting away those questions, and let's start with Leo, who says, greetings. I wrote a couple of weeks ago, my pop had non-TBI after SCA while on BiPAP in hospital. I've been trying to figure out how to get him home safely. We were on holiday when he became ill. I just need to quickly, what do you mean with SCA, Leo? I'll just quickly actually need to Google that. So SCA medical, let's just see what that means. It says spinal cerebellar ataxia. So some brain disorders. Pop had non-TBI after SCA while on BiPAP in hospital. So it sounds like he had stroke type of thing. Okay, let's just quickly carry on. On Friday, the clinical manager and host doctor said he would be transferred to local LTAC by the end of the day. I asked for further away LTAC just so we could spend more time in hospital. I don't want to be here, but as you stated, LTACs are worse off. We used up nearly all our money. I have no ties to this area, no family and friends, and don't feel comfortable heating up people with GoFundMe. What are your suggestions? Do we have a fighting chance? Right, I do remember, I think you posted some questions a week ago, a couple of weeks ago. I can't quite remember what those questions were, Leo. So, the first question that I have is, does your pop have a tracheostomy or no tracheostomy? Right? That is the question. Does he have a tracheostomy or no tracheostomy? You can get him home. There's no question around that, assuming he's stable. And the only thing that's keeping him in ICU is the BiPAP. Then he can definitely go home with intensive care at home. Right? There's no question about that. That's bread and butter for us. Now, I don't know where you are, but you must be in the US because LTACs only exist in the US. So, that would be my advice here. Go home if you think you can, and we can help you privately. I don't know where you are in the US. You haven't indicated that. What I can also do is to clarify your situation. I would appreciate if you could come onto the call here. I'll post the link here. So if you wanted to come on live on the show here, if you use the link, use the link and come onto the show and talk to me directly. You don't have to go on camera. I know some people are a bit camera shy. You can keep your camera off, but come on here and talk to me. That would be my suggestion. Okay, so intensive care at home is an option, but it would be good to know if your pop has a tracheostomy or not. That would be really good to know. Now, next, you're saying on Friday, the clinical manager and host of doctor said he would be transferred to local LTAC by the end of the day. I asked for the further away LTAC so we just could spend. You don't need to do that, Leon. You just need to tell them that you don't want to go to LTAC, right? The other question that I have here is, does he have a nasogastric tube or a PEG tube, right? If he has a PEG tube, odds are an LTAC will take him. If he has a nasogastric tube, odds are the LTAC won't take him. So, so I have some questions here. If you could answer them to me, Leo, that would be really great. A, does he have a tracheostomy? And B, does he have a PEG tube? But the bottom line is this, Leo, no one can force you to go to an LTAC without your consent, assuming you are the power of attorney, of course. I don't know the family dynamics that you're dealing with, but assuming you are the power of attorney, no one can force you to go to LTAC. And we've proven that over and over and over again, that as soon as you put your foot down, nothing's going to happen. And I'll come to that, to your comment where you said we've used up all our money. I'll come to that in a minute, because we just had a very interesting case with the client this week, where I think I have something more to say about, what the hospitals say about entitlements and what's actually happening in reality. Then you're saying, I don't want to be here, but as you stated, LTACs are worse off. We used up nearly all of our money. Okay, great. Great point. Now, Leo, keep in mind you're asking, do we have a fighting chance? You always have a fighting chance, Once you've given up, you've given up. That means once you've given up, you have no more fighting chance. You miss 100% of the shots you don't take, right? So, you always have a fighting chance. So we've published on our blog a document from a law firm in the US that hospitals have to get consent from families before they move them to LTAC. Now, here's another thing you need to keep in mind, Leo. we are 1 day away, or in my time zone, we are 1 day away from Christmas Day. In your time zone, you're 2 days away from Christmas Day. Hospitals want to clear out their ICU beds before Christmas to save money and send staff on holidays and all the rest of it, right? So you have to keep the dynamics in mind here as well. I've worked in the hospital system long enough to know what's happening around this time of the year. Okay, so then you don't need to think about, sending your POP to an LTAC that's further away. You don't need to do any of that. You just need to tell them we're not going to LTAC. It's as simple as that. And what you can do in a situation like that, you can make a complaint to a hospital executive. That always seems to work, right? People don't think outside of the box. What else can they do? Well, you should be making a complaint to a hospital executive. Hospital executive, like a general manager or a CEO, or whatever the title is, they can't really ignore the complaint of a family, right? If families are unhappy in ICU, they might make a complaint to the nurse manager or to the medical director, and they might just ignore it. They might think, well, we've kept you at arm's length for the last 2 weeks. We might as well keep you at arm's length because that's worked so far. By you taking this out of the area, by going to another level, they no longer can ignore that really. So that would be my advice here, Leo. Coming to the money side of things. So I'm not exactly sure what you are referring to, but let's just say that the hospital is telling you that your POP used all his hospital entitlements and that he needs to go and leave the hospital and go to an LTAC. Now, I argue you have to hear that from the health insurance and not from the hospital. So case in point. So this week we had a very similar situation. A hospital telling a family, oh, your mom has used all her entitlements in ICU. If we're not going to LTAC now or to a nursing home, you'll be out of pocket. Well, my advice to that is trust but verify. But I wouldn't even say trust in this day and age. I would say verify. So the client rang up the health fund. And the client said, well, the health fund told me she still has entitlements. The hospital blatantly lied to him, saying that his mother has run out of entitlements in hospital and that she needs to go. After checking with the health fund, it was a blatant lie. She still had entitlements, and this is a US-based client, and they said no, she can still stay. And there were many medical reasons why she still needed to stay. And that's why I keep saying over and over again, you're running blindly towards the fire if you believe every single word that the ICU team or hospital team is telling you. You're running blindly towards the fire, right? You cannot believe everything that they say. You have to verify everything, right? Another case in point. This week we were working with a client, and this week I was in a meeting with the doctors, and we were asking all the clinical questions. I asked about whether there were any cardiac conditions, like whether the heart is fine, whether ejection fraction was fine, whether there were any other concerns with the heart. And the ICU doctor said, no, everything is fine. Now, in the meantime, we looked at medical records in detail, and it turns out that she most likely had a heart attack in the last few days, because that's what we're finding in the medical records. Can you now see why I say, question everything? You have to question everything. It's selective talking, selective sharing of information. Unless you get access to the medical records, you can get a second opinion like you get through us. You'll have a very hard time in making informed decisions, have peace of mind, control, power, and influence. So, Leo, to come back to your situation, you always have a fighting chance, but you need to ask the right questions. Ask better questions. That's my advice. Ask better questions and get as much information as possible. Okay, so he has a trach. Thanks, Leo, for sharing that. So he has a trach and a PEG. You're saying core pack, but I'm not sure what that means. I would imagine you're referring to trach and PEG. Okay. So if he has a trach and he's on BiPAP, well, he needs to continue with ICU nurses 24 hours a day because, just give me 1 second. Just give me 1 second, please. I just very quickly need to respond to an urgent text. I do apologize. Okay, so if he has a trach and a PEG, you have a really the LTAC will take him. Any LTAC will take him with that, but that's not a good thing. So, if you had come to me by the time you would have needed to make a decision about a PEG tube, I would have said to you, do not give consent to a PEG tube, full stop. Right? Do not give consent to a PEG tube, full stop. That's what I would have said. Right? But in the meantime, don't worry about it. Okay, you can't turn back the tide here. But what you can do is simply put your foot down and say, we are not going to LTAC. And here are the reasons why. Ask them for the hospital discharge policy. And you will find two things. You will find A, they may not want to show you the hospital discharge policy because the hospital discharge policy will most likely say that your POP can't go to LTAC unless he's giving consent, or you or whoever the medical power of attorney is gives consent. Right? Simple as that. So, but one thing that I'm finding over and over again, watch what they do, not what they say. So here's another reason why I'm saying that. The more you push back, the more you will see that things will change for you. But you won't see it when you push back for the first time. They try and continue walking all over you. Push back the second time, and they might still try and continue walking all over you. Push back a third time, and they may still not give in. Push back a fourth time, then things might change. Push back a fifth time, and then things will change. But you have to keep pushing back. I am all for making friends. Don't get me wrong. Whenever you can make friends, make friends. But if you can't make friends and you need to save your POP, then don't make friends and save your POP. Make sure what's best. Make sure you get what's best for him. So the pushing back most of the time works, especially with my experience. You are A, you have nothing to lose, and B, you are in the right. Right? You are in the right. And we've seen it so many times. This week, like again with another client, we've kept pushing back, and it looked like the client was going to LTAC, and then at the 11th hour, the hospital pulled back and said, yeah, she can stay. We knew it all the way along that the hospital had no rights to send his mum to an LTAC whatsoever, and it'll probably be the same in your case, Leo, here, but you have to get that verification from the health insurance, right? Make sure you get that from the health insurance, right? So, because that's what the hospitals want. They want to intimidate you, get the facts, and the facts only. Okay, that is really important, because at the moment you're just believing everything they're saying, just as much as you believed he needs to have a PEG. Don't believe everything that they're saying. You have to do your own research. You have to get a second opinion. You have to have a specialist look at your case with a second opinion, look at the medical records, get them on the call, and make all of that happen. Very, very important that you don't take things for face value. Okay, So I really hope that helps you, Leo. Don't play that game. Don't try to go to another LTAC further away to buy you time. The one thing that you can do to buy time is you can say to them, you want to have a look at several LTACs. You can do that. Whether you do that then or not, that's up to you. You can probably just look at one and you will probably see why I'm saying don't go to LTAC. Have a look at their online reviews, and that'll be enough for you to tell them we are not going to LTAC, full stop. Right? So don't give in. 9 times out of 10, not giving in will give you all the results that you need. Okay? Be patient. Don't be intimidated. Don't be intimidated. Stand up for what you know is right, and don't be intimidated. I hope that helps, Leo. You know, and also if you do want to go home with your pop, let me know, because we can possibly help you privately. I don't know where you are, but just send me an email to support@intensivecarehotline.com and you know, say in the subject line something like you talk to me on YouTube. That's again support@intensivecarehotline.com, or you can also just call me on my US number. When you go to intensivecarehotline.com, you can call me there directly, and then we can see how we can help you further, because I know we can help you. Okay, so Tish20 says hello. Hi Tish, thank you so much for coming on to the show. Let me read out some more questions that have come in during the week. If you have any other questions, just type them into the chat pad, or come onto the show with the link that I just sent you here, the StreamYard link. You can also come live on the show if you want to talk to me directly here. We've got another 40 minutes left. Now let's just see what questions have come in during the week. Let me start with those questions. Okay, so the question that comes in from Kelly is, I just happened upon this video from my YouTube suggestions. It deeply saddens me and angers me as well to hear about this particular incident. My late fiance passed away in March 2020 after suffering the lower portion of his brain being cut off from oxygen for 9 to 12 hours. He was treated after suffering the lower portion cut off from oxygen for 9 to 12 hours. He was treated at Emory University Hospital in Atlanta, and it was made very clear to us that he knew what was going on but could no longer speak or breathe on his own, and that he was in a locked-in syndrome. They have a special way of teaching patients in this situation to speak through blinking their eyes, and had explained his situation to him 4 times and asked during each of those 4 times if he wanted to be kept alive through life support, and he responded no all 4 times. He had definitely made that clear to myself and his family earlier in his life, so we agreed, and a week's time was allowed to everyone to say goodbye to him. It seems so cruel that anyone could be misled by the healthcare team as to the true diagnosis of their loved one. I just can't imagine healing light being sent out for the family involved. Well, you know, in this situation, it looks to me like you have made an informed decision, Kelly, that, you know, you did no longer want to continue for your fiance to carry on, and that's okay too. You know, that's okay too. As much as I am pro-life and always say, you know, you got to carry on. If there's an advanced care directive and you have, you know, and you have, or your loved one has made their wishes clear, there's absolutely nothing wrong with following someone's wishes. You know, you just have to be clear about it. You have to be clear when not to continue, and you have to be clear when to continue. As long as there's clarity, there is absolutely nothing wrong with that. So, next question is from Jin. Jin says, hi Patrick, I would like to get some help here. My 89-year-old dad was supposed to discharge last Sunday, and the moment we moved him to The moment we moved him to the car, still at the hospital lobby, he suddenly collapsed. We then immediately rushed him to the emergency department. They did CPR for him and got his heartbeat back after about 26 minutes, and he was under sedation and intubations. He has been coughing and had aspiration pneumonia the first time he was admitted. Lots of phlegm, and we are still not sure the reason why he collapsed. He had multiple strokes previously, and the last one happened last Christmas and caused his right hand and leg not to move. He also had dementia and Parkinson's. The throat is not sensitive, he always chokes on liquid, but he was still able to take porridge before he got admitted. Back to now. He has been intubated for a week. Sedation was off 6 days ago. So far has not woken up. Yes, he's having some self-breathing, PEEP at 10, and breathing can go up till 24/25 breaths per minute. However, just last night, they tried to have a CT scan for him. Not sure what happened after that. The expiratory rate decreased. The doctor did a new round of intubations for him, saying that the tube connections wasn't good and it caused an air leak. They sedated him a bit again. Now, PEEP is at 10 and ventilator number is at 14. His kidney creatinine is increasing every day, now up to 320 from day 170. He's got an enlarged heart. The doctor said we can keep him as far as we want, but also worry the complications that may happen along the way. Tracheostomy has been mentioned as well as end of life. My family decided to keep him in hospital till the very last minute. We are worried. We are very worried, very scared. Here are my questions. Can they extubate him if he can self-breathe? As I search, saying ventilator too long may cause kidney failure as well. Dad's body is swelling. Do we need patient to be conscious before extubating him? Doctor also worried his airway got stuck back if they extubate him. Number 2, the doctor is not suggesting dialysis anymore due to his age and very weak heart. What should we do? Number 3, can we keep the tube ventilator for him without going for a tracheostomy? Thank you so much from Jin. Well, thank you so much, Jin, for sending this email and sharing about your dad's situation. So the first thing that I'm missing here is, have they done a CT scan of the brain? Right? CT scan or an MRI scan of the brain. That's the first thing that I would want to know. Got to keep oiling my voice. Have they done a CT scan or an MRI scan of the brain? He's been off sedation for 6 days and he's not waking up by the sounds of things. Can they extubate him if he can self-breathe? Only if he's awake, if he can obey commands, if he can cough, if he can protect his airway, if he has been passing spontaneous breathing trials, only then can he be extubated. Let's just say he can breathe by himself, but he can't cough and can't protect his airway, and he still needs a tracheostomy. But one of the missing links here is clearly have they done a CT scan or an MRI scan of the brain to ascertain how severe his brain damage is? Right? You have to find that out because everything else will probably follow on from there. If they've done CPR for 26 minutes, chances are reasonably high that he has some significant brain damage, and you need to find out to determine your next steps, right? Also, with an enlarged heart, that is probably a result of the cardiac arrest and the CPR they performed, right? You're also saying, I searched saying ventilator too long may cause kidney failure as well. Yeah, can cause kidney failure, but I think what's happened here is your dad had a heart attack or has been in cardiac arrest. His blood pressure plummeted. Because of that, kidneys hadn't been perfused, and therefore he most likely ended up with kidney failure because of poor kidney perfusion because of cardiac arrest. That is more likely what has happened here. My dad's body is swelling. Do we need the patient to be conscious before extubating him? Yes, you do. Absolutely do. Doctor also worries his airway got stuck back if extubate him. Yeah, very high chance if you extubate him in this situation, he'll he needs the breathing tube back in again. Not a good scenario. So what you need to do is, once again, do a CT scan or an MRI scan of the brain, potentially an EEG, and then determine what you want to do from here. Now, 6 days in ICU or a week in ICU after the cardiac arrest and prolonged CPR is probably not a long time. It's not a long time, and I wouldn't jump to too many conclusions just as yet. Even though the prognosis here is not great, I would still wait for now, a few more days. Then you are saying the doctors are not suggesting dialysis anymore due to his age and very weak heart. What should we do? Well, does he need dialysis? If he does need dialysis, can they give it a go? Right? What's his blood pressure like? Is he on inotropes or vasopressors as part of the cardiac condition? Right? If that is the case, chances that he can tolerate dialysis is lower, but it's still there, but it's lower. So, I'd say find out if he's stable enough to go on dialysis, and this is really where we come in. If I talk to doctors and nurses directly, or we look at medical records, we can find out these sorts of things very, very quickly. This is why a second opinion is so important, because you can't just take their word for gospel. You cannot take their word for gospel. And I've given you enough reasons just on this live stream or in other videos why you have to do your own due diligence always. Then you are saying, can we keep the tube ventilator for him without going tracheostomy? Not for long periods of times. You can, up to 10 to 14 days, but not much longer than that, because that's when the airway, becomes damaged, vocal cords become damaged. Chances are higher that your loved one will end up with a ventilator-associated pneumonia. So there's a number of many risks here when it comes to not doing a tracheostomy, right? The other thing that I would like to know is, what are his ventilator settings? He's saying they sedated him for a bit. Now PEEP is at 10 and ventilator number is 14. Well, what does that mean? Ventilator number at 14 could mean breaths per minute. It could mean pressure control, right? It could mean peak pressure. When someone is ventilated, there are many numbers on the screen on the ventilator, and you need to be able to interpret all of them, right? So I hope that helps, Yin. Let's move on to the next question. Or if you have a question here, please type them into the chat pad, and I will get to it, or come onto the live stream. There's a link that I put there if you want to talk to me directly here. Come on in, and you can talk to me directly. You don't have to go on camera. You can just keep your camera off if you're a bit shy. But talking to me is the quickest way to help you one way or another. Now, another email from Adam, who says, "Hi Patrik, I'm not getting the full picture or answers on how my mom had a PE. PE stands for pulmonary embolus, while under hospital care and ended up coding 2 times. Now she's on a ventilator, and I'm uncertain on just how much damage was done and if negligence on the hospital's part is to blame." Well, what a great question. Now, first off, PE again is a pulmonary embolus. When a pulmonary embolus happens, what happens is a thrombosis forms somewhere in the body and then migrates to the pulmonary artery, right, and causes a clot in front of the heart, which causes a cardiac arrest. That's the mechanics of a PE, a pulmonary embolus. Now, she coded 2 twice. Now she's on a ventilator, and I'm just uncertain on how much damage was done and if negligence on the hospital's part has happened or is to blame. Difficult to say. However, let's just say she was on a heparin infusion. Let's just say your mum was was a high risk to begin with. Maybe she has a history of deep vein thrombosis, then she should have been on heparin right from the start in hospital, and she should have been, they should have checked the APTT very closely. Maybe they didn't do that, and they missed increasing the heparin. So once again, we would need to look at the medical records in order to help you find out whether there has been medical negligence or not. We simply don't know without more information, right? So it's critically important that you get a second opinion here, or let me and my team look at the medical records, right? Now, reach out to us if you want a medical record review, or if you want me to talk to the doctors and nurses directly. Adam, just reach out to me by emailing to support@intensivecare-hotline.com, or by calling me on my US number 415-915-0090. That is again 415-915-0090. Now, let's get to the next question. And this question comes from Joanne. Joanne says, my mom had a cardiac arrest, but she's not waking up, and it means death. She's pronounced brain dead. Well, Joanne, I would verify that. I wouldn't just take the word for gospel. When someone is pronounced brain dead, in most countries and states, they're also legally dead. So I argue the stakes here are pretty high. So you better verify whether that is true or not. Better get access to the medical records and verify that. And even if the medical records say she is brain dead, you better verify that they've done the correct procedure, right? That 2 different doctors followed an algorithm and tested her for brain dead, and that both of them came to the same conclusion, right? A follow-on comment from Joanne's comment comes from Heva, who says, I'm so sorry you went through this with your mom. Cardiac arrest is very hard on the brain and body. It will take as long as your body needs to get better. Unlike being classed as clinically dead, there are apparently 3 tests they do before pronouncing someone brain dead. Do you know if they did these tests? Yes, absolutely. That's exactly the point. This is actually a YouTube exchange, on our YouTube channel, right? And this is exactly the thing. You need to verify whether they followed the right procedure, because what you might find is they might have tested for brain dead. She may not be brain dead, but they're telling you she's brain dead, and then they can potentially harvest her organs, right? I'm just sort of spinning it together. And then she says, I hope your mom did wake up and things are going good for you both now. So that's the YouTube exchange in the comment sections for this client, Joanne. Okay, let's go to the next question. And once again, if you have any questions here, please type them into the chat pad and I will get to them. Or if you want to come on live on the show, just use the StreamYard link and I will answer your questions here live on the show. Just click on the link. Now, someone with the name of South Park Comedian on YouTube made a comment this week who says, my mom is 61. She had a heart attack and cardiac arrest for 30 minutes. It has been 5 days. She's awake. She's breathing on her own. She reacts to stimulus and she will use her eyes and head to follow you. We are not sure to the extent of her brain injury, but all these signs give us hope. She still has the ventilator in because she isn't following commands, and the doctors are afraid she won't be able to clear her airway. We need to make a decision on putting in a tracheostomy or letting nature run its course. Well, who says you need to make a decision? Who's telling you that? I'm constantly gobsmacked by, hospitals telling families, well, you need to make a decision now. You don't have to do anything. What you have to do is getting information, getting a second opinion, and making sure that you are on the right track. That's what you have to do. That's the only thing you have to do. Doing your due diligence, making sure you are on the right track. If she's breathing on her own and she reacts to stimuli, she will use her eyes and head to follow. Why would you not use that as a sign that things are moving forward, although slowly? She still has the ventilator in because she isn't following commands and the doctors are afraid she won't be able to clear her airway. We need to make a decision on putting in the trachea or letting nature run its course. Well, here's the good news, South Park comedian, that you might take the ventilator out and she may not pass away. Then you can't let nature take its course. I think your only option here really is to get a trach done and see how she recovers. If she can recover, if she can't recover, there's still plenty of time to talk about end of life. But you're not at that point, right? You are not at that point. In the meantime, keep asking for what you want. Keep asking for the trach. Don't give consent to a PEG, and then give her the time to wake up. That's really what it comes down to. Give her the time to wake up. That's all it is. Okay, do not give up. Now, next question comes from Mylanda, who says, one theme I regularly see is when a family is more assertive and life support remains, the doctors always say we must wait and see. There is reluctance to prognosticate with a survivor of a brain injury. When the decision is being made, however, there's often pressure on the family to give in. Yeah, don't give in. You cannot control other people, but you are 100% in control to how you react. You are 100% in control of that. Keep that in mind, right? And of course, they will be reluctant to prognosticate with a survivor of brain injury. Well, so am I. I am not here to prognosticate what a survivor of brain injury, what quality of life a survivor with a brain injury will have. I cannot tell you. I can absolutely and confidently not tell you what, prognosis a survivor of a brain injury has. One thing, though, is crystal clear to me. You will never know when you're pulling the plug. That's for sure. You will never know the outcome of survival when you're pulling the plug. It's as simple as that. Giving up, I believe, is never an option. Or if you do give up, you need to be very certain in terms of what you're doing. Also, brain injury patient in ICU often is sort of the worst case scenario for an ICU. What that means is the worst case scenario for an ICU is looking after a patient indefinitely with an uncertain outcome. Once a patient, for example, has a trach, they could be stuck there forever and a day. So therefore, they are, your loved one probably represents the worst case scenario here for them, which is once again why they're negative. So just keep that in mind as well, that your loved one is probably representing the worst case scenario for the hospital. Okay, let's move on to the next question that comes from BT, who says, my mother just passed out yesterday in a cardiac arrest situation and was taken to the hospital. I went with her in the ambulance. She's type 2 diabetic, and when they checked her vitals, the blood sugar was up to around 230 systolic. Currently, as of now, they told me through the phone that her vitals are solid, just low blood pressure and fluctuating glucose. She is unresponsive, and it has been confirmed that she has brain damage according to what the doctor told me. They did her CT scan and it went well. They just put another IV line through her recently today. I just hope she does wake back up and will return home well and in one piece. Well, again, if she has 230 blood pressure systolic, she needs a cardiology review. She needs cardiologists involved, especially after cardiac arrest. She's unresponsive. Well, is she on sedation? That's the first question. is she still on sedation? Is that why she's unresponsive? You know, is that why she's unresponsive? Okay, so then does she have seizures? Right? Does she have seizures as part of the cardiac arrest? Right? If she has seizures and she's off sedation, is she getting anti-seizure medications? And they often have a sedative effect, if that's why she's not waking up. Right? You're saying they've done a CT scan and it went well, but what does it actually show? What does the CT scan of the brain show and the MRI scan of the brain? Right? And you will need to give it some time. She may need a tracheostomy as well. Right? She may need a tracheostomy. Right? So keep all of that in mind. And get access to the medical records as soon as possible. Get access to the medical records as soon as possible. Right? And get a second opinion. Get me on the call with them. And get me on a call with them. And I will ask the questions that you haven't even considered asking, but you must ask, so that you make informed decisions, have peace of mind, control, power, and influence. Okay. With the glucose, she probably needs an insulin infusion. There are many patients in ICU that have a high glucose, which is temporary. It's a stress response from the body. The body simply produces more glucose during such a stressful event as being a patient in ICU. So you shouldn't worry too much about it. That's assuming your mum is not a diabetic patient, that she hasn't diabetes. And also get the results of the CT scan, of the MRI scan, of the EEG, and make your conclusions from there, and reach out for help if you need to. Okay, let's move on to the next question. From Pamela. Pamela says, my husband is in a drug-induced coma and kidney failure, and he's 71. He has been 3 months in hospital and has not come out of a coma fully, and has had 3 bleeds, sepsis, and it's bad. Please help me. From Pam. So, Pamela, if your husband is in a drug-induced coma and kidney failure, and he's 71, and he has been in hospital for 3 months, the first thing that stands out to me here is that he may not have a tracheostomy, because after 3 months on a ventilator, he should have a tracheostomy, which would eliminate him needing an induced coma, right? But again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. You are saying he has been in hospital 3 months and has not come out of the coma fully, and has had 3 bleeds and sepsis is bad. So the goal of a tracheostomy is to wean someone off a ventilator, but more importantly, to get them off sedation as quickly as possible and get them out of the coma. That is the goal of a tracheostomy, and it doesn't sound to me like this is what you've done. My other advice is, and this may sound harsh what I'm saying now, take full responsibility. Take full responsibility for everything that happens. Because once you do that, it puts you in control. It's counterintuitive. It puts you in control once you've taken on that mindset. You know, if you sort of say, oh, what is the intensive care team doing? Okay, they're doing what they're doing. But once you take control of a situation, and even if it's only in your mind, you will see that things are changing. Change the way you look at things. The things you look at will change. Right? So especially if your husband is in kidney failure as well, even more important that they get rid of the sedation and the opiates. Even more important, right? Because all of that stuff is impacting on the kidney, but also on the liver. But it sounds like a farce to me that he's been in hospital for 3 months and he's still ventilated without a tracheostomy. I can't believe that, but that is what's happening. I understand that. And even though he has bleeding issues, right? Maybe he's on heparin. They need to stop the heparin for a trach. right? Or he's on Levinox or Clexane. I don't know. Again, the more information, the better. Okay, so let's move on to the next question from Dove, who says, my husband David is in ICU with aspiration pneumonia. He's 71. He was put in a coma and has not fully come out for a month. At the hospital, always hinting on pulling the plug. David has gotten sepsis, kidney damage, bleeds, and swollen body. He has been in ICU for 3 months and they are tired of him. What can I do? I blame the hospital for some human errors with his care. They didn't feed him for many days and limited water, which I think led to his kidney failure and swollen body. They gave him heparin R when I said not to and got 3 bleeds. He aspirated numerous times because of the feeding of the PEG feeding and food contents not going into his colon but up his throat. His colon is also not working and his stomach is atrophied. Can someone survive this? I think he can't without a miracle. Well, I think he can survive it, but obviously he needs more interventions. Now, I just need to actually change my position. I do apologize. So, sorry, and I just need to go back to that email. I do apologize. My husband David blamed the hospital for some human errors that didn't feed him for many days. Yep, that should definitely, they should definitely feed him all day, every day, right? And that's again, you need to put the pressure onto the hospital. And that's why you have to do your research from day one. Not feeding your husband is completely inappropriate, right? And that would harm him. Patients in ICU need nutrition from day one, right? The hospital is hinting on pulling the plug. Don't be worried about that because it's up to you. It's not up to the hospital to pull the plug or not. It's entirely up to you. David has gotten sepsis, kidney damage, bleeds, and swollen body. He has been in the hospital for 3 months and they're tired of him. What can I do? You're saying they didn't feed him for many days and limited water. Sometimes you do need to limit water intake to wean patients off the ventilator. You don't want to fluid overload the lungs, especially if he's in kidney failure. So they may have done the right thing there, right? But if they gave him heparin and he was bleeding, did they not use the right dose of heparin, right? That's the question here. He aspirated numerous times because of the feeding PEG and food contents not going into his colon, but up his throat. His colon is also not working and his stomach is atrophied. So if his colon is not working and he's potentially having a bowel obstruction or bowel obstructions, what can you do about that? Well, have they given him laxatives, right? Have they stopped the feeds? Have they given him TPN? What's TPN? TPN is total parenteral nutrition, also known as intravenous nutrition, right? So, have they done that? And his stomach is atrophied. Yeah, if his stomach is atrophied, he wouldn't be absorbing his feeds. And if he's not absorbing his feeds, he is at risk of bowel obstruction, malnutrition. There are so many risks. Can someone survive this? Yeah, I think he can survive it. When you look at the statistics, approximately 90% of families, 90% of patients in intensive care actually do survive, right? But the question is, what's their quality of life going to be like down the line? How much recovery time do they need, and so forth, right? That's really what the question is here. But as you also know, I would have never recommended for you to give consent to a PEG tube. Never ever, right? So keep that in mind as well. So I hope that helps. Dove from Pam, not from Dove. from Pam. I hope that helps. Pam, to answer your question. Now, time, last round of questions. If you have any questions, I have another 5 minutes left. Type your questions into the chat pad here. If you have any other questions, if not, I'll read out another question. There's plenty of them. Let me just see what else we've got. Oh, that's a long one. From Paul, who says, my brother is 73, has been on dialysis for over a year, twice in a week. He had a heart attack 12 days ago. ICU team implanted 2 stents in his arteries. During the procedure, he had a cardiac arrest for about 8 minutes before they were able to revive him. He hasn't been able to wake up 2 weeks from now. He sometimes opens his eyes and squeezes his hands if we ask him to. The neurologist said he will need longer time to recover, but his brain is good. However, they weren't able to give him dialysis twice last time. Right. Well, one of the reasons that sometimes patients can't have dialysis even though they need it when they're in ICU is simply that their blood pressure is too low. One way to manage that is potentially by giving inotropes or vasopressors to increase the blood pressure, or to give a blood transfusion depending on hemoglobin levels, platelet levels, INR levels. It depends on that as well. So, again, you have to dig deeper. When someone says, oh, your loved one can't have dialysis, well, you have to ask why, and is there a remedy for it? And ICU just says, oh, well, he's too unwell. Well, that's not good enough. That's not enough information. You got to dig deeper than that. Medicine has come a long way to achieve miraculous outcomes at times, but you have to ask for it, and you have to know what to look for and what to ask for. Okay, so I do want to wrap this up for today. I do want to thank you for coming on live to the show. I do want to thank you for your questions here. I also want to thank the viewers who watch this on replay. You can also leave your questions, and I will get to them probably on the next YouTube live. Once again, I want to thank you. Now, we have a membership for families in intensive care. When you go to intensivecarehotline.com, by intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day, and we answer all questions intensive care related in the membership area and via email. I also offer one-on-one consulting for families in intensive care over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly. I talk to you and your families directly. And I ask all the questions that you haven't even considered asking with the doctors and the nurses. And I also talk to you and your families. Of course, I can set you up with questions directly, but the shortcut really is me talking to them directly, making sure you make informed decisions, have peace of mind, control, power, and influence. Furthermore, I also represent you in family meetings with intensive care teams. So that first thing is, you need to consider whether you should even go to a family meeting or not, right? And if you do go, you need a strategy. You can't just go in there blindly. You need to have a strategy how to manage them. And, because I'm a clinician myself, I've specialized on family advocacy in intensive care. I know how to position your loved one's condition, once again, making sure that you can make informed decisions, have peace of mind, control, power, and influence. We also offer medical record reviews in real time so that you can make informed decisions, have peace of mind, control, power, and influence in real time. But more importantly, it's giving you a second opinion, right? We also offer medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are simply suspecting medical negligence. Lastly, if you like my videos, subscribe to my YouTube channel, click the like button, click the notification bell, comment below what you want to see next or what questions and insights you have, and share the video with your friends and families. Thank you so much for watching. This is Patrik Hutzel from intensivecarehotline.com, and I will talk to you in a few days. Take care for now.